According to the World Health Organization, 300 million children, teens, and adults worldwide struggle with the debilitating illness of depression. Join our discussion as we talk about finding hope and healing in the middle of depression next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with Dream Life Psychological Services. More than just the blues or a bad week or a bad month or year, the illness of depression is life-draining for those who experience it, and often mystifying for friends and family members because things don't always look so bad from the outside, or because often it looks to family and friends like the person isn't trying hard enough to get better, when actually many people with depression don't even know that's what they're experiencing. And the ones who do know are trying as hard as they can to stop their suffering, because we all know nobody really wants to continue to suffer. Tonight, we're going to shed some light on the illness and treatment of depression. So if you have questions about depression, call them in now. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. My guests tonight are Dr. Steve Bauer, the medical director at the Human Development Center, who's board certified in child, adolescent, and adult psychiatry, and Dr. Dan DeAllard, licensed psychologist with Duluth Psychological Clinic. Now, before we get started, I do want to say one thing and to remind our guests that now and throughout the show, so that's your cue to put up the graphics that we have. Now and throughout the show, we're going to be showing 24-hour hotlines. One is a telephone line and another is a text line that you can call or text in if you currently are feeling suicidal, because what we know is suicidal thinking is a part of depression, one of the symptoms that many experience who have depression. And of course, if it's an imminent emergency, we want you to skip those numbers and just call 911. So, very important. But let's get started and talk. I mentioned that suicidal thinking can be one symptom. What are some of the other symptoms that we see, Dr. Bauer, in depression?
So the DSM, our Diagnostic and Statistical Manual, usually looks for us to have more than 5 symptoms of the 9 that we talk about. So sleep problems, appetite problems, energy problems, concentration problems, crying for no reason or crabby all the time, hopeless, helpless, suicidal, lacking interest in usual activities, and when you become an adult, we talk about lack of interest in sex.
And in children, how might that be a little different?
The symptoms overlap a great deal, but children and adolescents differ in 2 significant ways. Oftentimes, low self-esteem is what we notice first, comparing yourself unfavorably to other kids, etc. And sometimes the dysphoric mood is not just sad, but irritable or crabby, as Dr. Bauer said. That's often how kids will present with the dysphoric mood part of that syndrome.
And my own experience also is that a lot of people will just deny being sad or depressed.
Certainly.
And that something is wrong and something is off and not right with them.
So when I started training, it was said that men had alexithymia, which is a fancy Greek way of saying can't describe their feelings, right? And I don't think all men have alexithymia, but I do think that lots of people have difficulty understanding or identifying for a variety of reasons, including stigma.
And I think that stigma piece is a huge part of that, particularly in men. Last week on the show, we had Michelle Heinen talking about the suicide rate and how men white men in particular, between the ages of 50 and 59 had one of the highest suicide rates. And so what do you see in your own practice, Dan, about men's ability to seek help? Let's talk, since we're talking tonight about depression, and how they come to seek help for that.
As Dr. Bauer said, there's certainly a stigma for all people about acknowledging depression, first of all to oneself, and then to others, and then to seeking help for it. The efforts that you've made and shows like this have made and people all around the country have made to reduce that stigma and allow more people to speak up just as if their leg hurts, they get help for it. my heart hurts, my head hurts, I need that help. So it's improving, but it's still a real thing. And often we need loved ones to push by expressing concern and love and hope that they can feel better to get folks into the office.
And I think sometimes loved ones are noticing things maybe even before the individual themselves, where especially if you have this sort of gradually ramping up of symptoms, this gradual worsening, it's like putting the frog in the boiling pot of water, turning it up for a degree. You keep adapting to the wrong thing, and meanwhile friends and family can see like this is a miserable human being now.
Yep. So lots of people have endured lots of difficulties, and certainly when there are known stressors, we tend to try to ignore it and move on, as opposed to looking for those symptoms and recognizing, particularly in families that have a genetic vulnerability, that there is a more serious and debilitating component to that, right?
And so that one of the things that you just said then for our viewing audience is that there are some types of depression that are heavy genetic based and that make other family members, particularly those first degree family members, daughters, sons, more likely and more at risk to develop depression in their life.
Very much so.
And so what would your advice be, Dan? So if you have like a parent out there who knows that they have depression, and sometimes, you know, parents want to kind of shield their children from that knowledge as well, or not burden. I mean, from a heart coming from a good place.
Right.
And what would your advice about that be?
My advice would be to be especially vigilant about early signs of depression in your children. So things like withdrawal from usual activities, less pleasure from usual activities, sleep or concentration problems, and disclose to in an age-appropriate way with your children your own struggles. You don't have to use the word depression, but you might say, hey, I've recognized in my own life I'm susceptible to getting really down at times. If you ever experience that, please talk to me about it.
Because we talk with our kids about family risk factors for physical health problems, right? Like our family has risk, like has a lot of breast cancer in it, so you need to make sure you're doing all of the right things here. And so we really should not be treating mental health issues like depression or any other mental health issue any differently then.
Absolutely.
Now, you mentioned, Dan, that self-esteem problems, particularly in kids and teens, is a good marker. And the thought that went through my head when you said that, and we would differentiate that from usual teenage self-esteem. How?
Good question. How pervasive it is, how long it lasts, and how it affects your behavior and your functioning. All of us take self-esteem hits. You're living a very sheltered life if you don't. But most of us recover from those hits. We balance a self-esteem hit in one area of our life by how well we're functioning in other areas. If we don't recover from self-esteem hits, if we start doing less well with academics and in sports and when we play our instrument, etc., then we need to start paying attention to that. That's a self-esteem problem that may be broadening into a depressive syndrome.
And how often, Dr. Bauer, do we see suicidal thinking as part of the picture of a person's depression?
Well, so that symptom in particular tends to be very sensitive to people's values and how much their ability to see value in themselves and the world as they go forward. And so different people, we talk about protective factors, and certainly people who have strong faiths that are part of a religion that sees suicide as a absolute sin tend to be protected by that belief. Now, I've met lots of people who, in spite of being in those kinds of very good organizations, they're still struggling with that symptom. I don't have a great number as to what the percentage is, but I do think it's fairly frequent, particularly when we get more severe cases, and the recurrent cases become more urgent as people feel like this is never going to stop, right?
So, you know, one of the things that you mentioned, which is so ironic, is that religious faiths who considered suicide a sin, because what we would say is like, oh, not a sin, it's a symptom. And so the irony of that is something that really is a belief set that is not in keeping with how we view depression as an illness, winds up being an ironic protective factor for some people. Although there are also other protective factors, like feeling a sense of responsibility for family, feeling a connectedness to life that is just, that can be against your value system and not necessarily against your faith as well.
And I think people's experience with other family members and friends where people have tried to commit suicide or committed suicide absolutely influence other people's then expression of that.
That's an excellent point. And what's your experience been with that, Dan?
To know someone who's even attempted suicide, much less completed it, is to profoundly alter your sense of how a suicide will ripple through everyone who knows you, and itself can be an incredible protective factor. On the other hand, and this alarms us clinicians to no end, fantasies of reunification with people who have committed suicide is something to be addressed.
So here is a question, Dan. Sam from Superior asks, are there any, he said abnormal, and I'm going to say really different, ways that depression can present, or is it always just people that are sad?
No, sadness often is the lead emotion, but as we discussed before, to feel hopeless, to feel angry and irritable, short-tempered, to be very withdrawn from your activities, to not see any purpose or meaning in life, interpersonal withdrawal, sabotaging relationships. So any of those things can be the lead, but as Dr. Bauer mentioned earlier, what we look for primarily is dysphoric mood of some sort and loss of pleasure or interest in activities. Those almost always tend to be present.
The blondness, the gray.
Yeah.
I had a client say to me, it's not that it feels black, it feels gray, and that there's no color in the universe for them.
Millions of ways people describe this, and every one of them is valid as they try to communicate with us what it is they sense. Within our literature, there are kind of the typical and atypical presentation, where atypical is mostly associated with carbohydrate craving, increased sense of both sleep and eating, along with fatigue in a more complete way. Older melancholy depression, where anhedonia or lack of any pleasure and feeling are associated more with sleep difficulties and less sleep, and then more diurnal variation, where mornings are in particularly difficult, and then people start to pick up steam later in the day.
So now that we've been talking about what depression can look like, let's start talking about, it has frankly sounded kind of sad. So let's start talking about, because I did say that there is some hope to be had here. Let's start talking about, what does treatment look like?
Yeah, 3 pillars of treatment, and we see this clinically and the research supports it. The first is talking with a supportive person, often a therapist, but it could be an informed family member. Medications are often remarkably effective for therapy. And getting involved in pleasurable relationships and activities in your life. So self-care, medicines, and therapy are the 3 legs of the stool for treatment.
And certainly that there has been an explosion of medications since the first medications, 1959, were older, had more side effects associated with them. In the mid-'80s, the new SSRIs, the real benefit to the SSRIs.
Of which Prozac is the most commonly known.
Prozac was the first and most commonly known, and at one point the most widely prescribed drug in our country, but have several other versions of it now. So those are some of the first medications that had fewer, certainly not no side effects, but some people experience mainly the benefit without side effects, and that's always been one of the difficulties with medications, is how many side effects do you balance with the improvement that you get.
And I know that somebody has the question out there, so I'm just going to ask you for it because apparently you haven't called it in yet, which is, do all people who suffer from depression need to be on medication?
There are several people, types of people where genetically, probably, they're more sensitive to medication. And so lots of people have tried medicines and decided for them it's not what they need. It certainly complicates things for some people, but I don't think it is absolutely necessary. And as Dan has said, the research is very clear that the majority of people who respond to the combination of things.
And we're really there. We're talking though, but you're going to correct me if I'm wrong on this. On the moderate to severe levels of depression and more milder depression, you may be able to get away with therapy.
You sure might, and part of it, as Dr. Bauer said, is how genetically susceptible are you to depression. It's also how effective is your therapy and your greater engagement in activities that you enjoy. But yes, certainly people do. I should also say that 80 to 90% of people who suffer from depression recover, at least temporarily, from it, and often for a very long time. There's a great deal of hope around depression. We've come to understand it as, for some people, a recurring or chronic illness. But many people do have episodes of recovery, very long episodes of recovery. For not everyone does it recur. So while we understand it more and more as something we may need to manage over a lifetime, people get better and get depression free. We talk so much about symptoms, and boy, that can be a crushing list of symptoms, but people recover.
And here's a question from Lydia from Carlton, who wants to know, how do I know if and when I can stop taking medication for depression?
That's a great question. So, most of the good evidence, and as Dan was saying, the group of people who have a significant depression and then recover and never go on to have another significant depression is, at least in theory, quite high. Mm-hmm. And so when we've looked at this specifically, the research shows that you need to take medicine for about 6 months of doing better, and then your risk of getting another depression is the same as everybody else. If you take it for less than that, then theoretically, according to this research, your risk goes up.
This is kind of like taking the full course of antibiotics. So just because you're feeling better on day 3, do not stop taking them.
Absolutely.
And that's hard because often, we're really good, we human beings are really good at being taking medication when we're symptom driven, right? Have a headache, I'll take some aspirin. But the I feel good, I know I'll swallow a pill is something that most of us don't do, and it's hard to remember and hard to think about.
Very much so.
And yeah, maybe even more so when you're depressed, or more so when you feel like I've gotten over that, I'm done. I want to get back to my quote unquote normal life. Yes. I don't want to be taking a pill to feel good.
Yep, and feeling artificial is something I hear as the reason that lots of people repeat this mistake that they know each time that they come back and want to restart medicines but haven't kept up with it for that reason.
Now, Dan, you keep talking about one of the main things that people need to do when they're depressed is to get back engaged in life, to get physically active and socially active.
That's right.
And yet, when people are so depressed, that feels, you feel like you're super glued to the couch. It feels like I don't know how to stand up and go do that. And so tell me what helpful things you tell people where that's a huge, it's like, oh, I know you're feeling really bad and I'm going to ask you to do the one thing that seems impossible. Aren't I helpful?
Right. Makes them really want to come back and talk to me again,
right? Yeah.
The metaphor acting as if is really useful. In daily life, when we're well and not depressed, we tend to do what we want to do. Depression takes away the want to. But if we can get ourselves to act as if the want to is there, sometimes the want to follows the doing of the action. So if you're withdrawing from relationships, you're putting in half an effort at work, you're not walking, etc., push yourself to do those things, maybe even just one, and then the want to follows, and the emotions follow the behavior. That's often where I start.
And I think that that's just excellent, because one of the things that isolation does is that it doesn't give you an opportunity to have the positive life
That's right.
experiences
That's right.
and to have the alternative perspective, to have the reminder of, I like this, this is meaningful.
Yeah.
And other times people will say, it's so hard because I watch other people having a good time, and it makes me feel even less a part of things. And you would say what to them?
So quite often we watch and those negative thoughts become part of our reasons for not. And trying to identify them as that and then changing those are the things that, if you can be successful with that. And the other big thing that I try to get people connected to those folks, as Dan had said earlier, having positive people around you, trying to reach out and get people that know what's going on with you and allow them to help you get moving again, right?
And I think what I would say to friends and family is don't take no for an answer.
Be persistent.
That you can go to them, right? You don't have to just invite them. You can go to them. You can sit with them. You don't have to. It doesn't have to be about how are you feeling today. You can just sit with them. And sometimes the presence of a loving, caring person reaches people in a way that the helper person doesn't appreciate how meaningful that can be.
To be present with someone who's suffering can often be enough. To listen intentionally to whatever they have to say can often be enough. You don't have to have the cure. Companionship and listening themselves can become the cure, actually, at times.
Dr. Bauer, Carol in Two Harbors asked, how do I know if my anxiety is accompanied by depression? Which I think is a really great question.
It is. It's one of the most common connected or comorbid, we call them, illnesses. And we use these English language things, and those of us who study brain chemistry at times tend to meld things that are overlapping. And so one of the interesting things for me was really that those medicines that we mentioned earlier, the SSRIs, were really studied first in depression, but they've been studied as helpful in certain kinds of anxiety disorders as well. And so the differentiating in this case may not always be as necessary until you get to the therapy side, when I think it is important that there are specific tools that we try to use around anxiety, and we look at that then as more of a ongoing problem as opposed to this episodic thing that depression could be.
And you would treat somebody who had this co-presentation of anxiety and depression how, Dan?
Well, some of the same principles that we use in depression work for anxiety as well, but what we'd add in addition is, what are the roots of the anxiety? Is it ongoing life stressors that's prompting that? Is it your thoughts and beliefs about yourself or other people in the world that prompt it? Or do you have exaggerated beliefs about threats in your environment? So we try to get to the root of the anxious thoughts. We try to kind of control what your body's doing in response to anxiety with relaxation or mindfulness tasks. So there's some overlap, and then there's some specific things we do with anxiety. Depression and anxiety are pervasive, but they respond really well to types of treatment. And
those folks often are showing like that opposite end of the spectrum, where they're having difficulty sleeping. They can't turn their brain off. They feel this physical agitation.
That's right.
Then. And so the message and what you keep saying over and over is that we have good treatments, and there are people who feel like they are running out of options, where they've worked through many different medications. They've maybe tried ECT, they maybe have tried different therapists. And so I'll go to you first, Dr. Bauer. What would you say to those people who feel like I'm running out of options here?
Well, there have been lots of things that are being developed still, and there are other versions. And as we age, as we mature, there are always new looks that we can take at even old versions, right? So it's still likely that treatment will eventually provide some relief, if not complete relief.
And your quick message of
Past
hope.
is not always prologue in treatment. You're a different person at different times in your life. Therapy and medicines can work this time when they didn't last time.
And try a new therapist.
Amen.
You might need to try a new therapist, because sometimes how we hear things can kind of vary. Somebody can say something just a slightly bit different, and it can strike you like nobody's business. So thank you so much for joining the conversation. A lot of you were calling in questions. We didn't get to all of them, but we tried to do the best that we can in the short time that we have. And just to remind you that this Saturday, October 13th, Carleton hosts their 10th annual Suicide Awareness Memorial Walk. You can find out more information on our website at wdse.org/speak, where you can rewatch this episode, look up an old episode, or just binge watch all now 146 episodes from our 8+ seasons on the air. Join us again next week when we'll be talking about adverse childhood experiences and creating a legacy of resilience. That sounds like a good thing, doesn't it? I'm Dr. Carolyn Phelps. Thanks for watching, and good night.